Often, when we talk about apheresis, we are talking about a therapy that is particularly suitable for vulnerable patients, that is, elderly patients or patients, for example, who may be at increased risk of infections. Do we have any data on this? Are there data on the use of apheresis in elderly patients or in, for example, pregnant patients? What can you tell us about this?
The patient is what encourages you to think sometimes of apheresis in clinical practice, because I have safer treatment with a better safety profile, which is attractive not only for us, but also for the patient, which is something they value very much. But the data we have are predominantly from Japanese patients who are, unsurprisingly, elderly. In our environment, we have much less direct evidence on elderly patients, or almost none, very little. But at least I can contribute with my experience. This is a population that usually accepts apheresis most because of everything the therapy entails. Coming to the hospital, the concept of treatment. They accept it even better than young patients, although young patients who understand the treatment also find it attractive. And there is certainly no difference in the rate of adverse effects, even if they are few. There is no difference in older versus younger patients. And with regard to pregnant patients, if the evidence with older patients was limited, it's almost nil with pregnant patients. Experience is based only on anecdotal, isolated cases, although I see no contraindications for the use of these therapies. If there are none for the immunosuppressants we commonly use, I do not see the recirculation practiced in this therapy as a contraindication or a problem for treatment in these complicated populations.
We'll see. Let us now move from safety to efficacy. In fact, there are a couple of questions from the audience on combinations. Iago has published a couple of experiences with combinations of apheresis with anti-TNF, combinations of apheresis with anti-integrins. There are two aspects to focus on here, aren't there? Is it better to combine it with anti-TNF? Is it better to combine it with vedolizumab? How do you combine it?
I think we could talk about combinations for 1.5 more talks because of all the clinical and basic ramifications it can have. But here's the message that we have been getting after looking at this issue. Both are feasible in the clinic. It is true that when we look at our two cohorts, vedolizumab proves worse. It is also true that the patients who have made it to vedolizumab thus far are patients who were worse off. It was their last chance, and apheresis was added after failing vedolizumab. So it should be given a chance in a slightly more comparable setting. The feeling with anti-TNF is possibly better, on a personal level, and the data is also somewhat better. But I believe that this is not a black or white issue when we apply it, as in most of the issues we discuss. Just like issues regarding levels, just like other issues. I don't think the combination is applicable to all patients, because a patient who fails an anti-TNF, to give an example, with a moderate severe flare-up, more severe than moderate, I don't think that's the scenario to use apheresis, right? But in patients for whom you don't want to throw away the opportunity of an anti-TNF, who don't have a severe flare-up, who have persistent activity on endoscopy, with a more mild, moderate clinical impact, I think sometimes some extra help is needed. You use topical corticosteroids, optimize and do all the tricks you can think of to not lose the anti-TNF, and intensify it, of course. And this option is attractive to our patients, because once you lose that biological, you can't go back. It's that sometimes the activity is not serious, and you force the patient to make drastic changes in a disease with a treatment that you can then sustain, combine and play a little more in their favor. I think vedolizumab has comparable results, but the scenario in which it was applied was much more complicated, of course.
One of the questions that often arises from using and managing a pheresis is how long and how often. Do you really think that fecal calprotectin could be used as a guide to know when to stop or start increasing the interval between apheresis sessions?
Do you mean during induction or during maintenance?
The question is when to stop. I mean, do we only do induction? Or if you decide to do maintenance therapy, how often should you do it?
Okay, I think calprotectin is very useful for patient monitoring, although it sometimes scares us. I think it's something like radiological changes. It is true that they give us a lot of guidance, but it takes time for its normalization, and we see patients with moderate to severe flare-ups who take several weeks to gradually normalize calprotectin. So I would not use it during a relatively early apheresis induction. I would use it more towards, let's say, the last third part of an apheresis induction, of course. During treatment, before the third or fifth session, we do not use analytical tests or calprotectins, rather because it will not serve as a biomarker. We wait to see a change so that we can compare that trend and how the treatment we're using is doing 1 month after starting the therapy. This is what we put on the sidelines. I believe this should not be done too late or too early. And during treatment, is there evidence, as with other therapies, that early normalization is in favor of treatment response? I believe that we should not throw in the towel because of the way the mechanism works. And even if the calprotectin has not normalized or improved significantly after several weeks of treatment, I think it is necessary to keep it up and be a little more patient. Therefore, a little more caution should be exercised when using this therapy with more severe patients.